Recording in progress.
Úgy tűnik, hogy van váróterem, Can you hear us? Hi, hello, hello. So, welcome to the last session of this COIL course, Clinical Anatomy course, from Pécs. Our speakers are Andrea Tamás, she's an anatomist colleague, and her husband, Zalán Szántó, he is a surgeon, and they will talk about the chest deformities, the clinical anatomy of chest deformities. The rules for today's session are the following. Whenever you have any questions during the presentation, you can just raise your hands in the Zoom with the yellow hands, because then we see who want to ask something. But if you have questions which you want to put in the chat in Zoom or in the chat of the YouTube channel, just put there your question, but we will answer those questions at the end of the presentations. So basically these are the rules. I think we can start the presentation. So please Andrea, start your presentation.
So I would like to welcome all of you in this very special clinical anatomy session. It is a very big pleasure for me to be here in this very special event, because it is a very first opportunity to use this very interactive form of the clinical presentation, clinical anatomical presentation. So today I would like to talk about the anatomy of the thorax. And after Zalán Szántó, he's a thoracic surgeon, he will talk about the clinical operation, how they can operate the different deformities of the thorax. So first of all, I would like to show you the main parts of the thorax. Here is my help to show you these main bones. Of course, we have a sternum in the middle. We have to talk about 12 pairs of ribs. And the thoracic vertebrae, these are the main parts of the thoracic cage, the thorax. First of all, I would like to show you the main parts of the sternum. The sternum consists of three main parts. The first part is the manubrium. After, we can talk about the body. And finally, here from this preparation is missing the xiphoid process. Here you can see also these main parts on the wall. If you see the manubrium first, on the top you can see the jugular notch. It is very important part of the thoracic cage. It's very important point. We can use it in the orientation. And after, here you can see the articular surfaces for the clavicle. It's called clavicular notch. Here you can see on the lecture. And after, we can see the articulating surfaces for the first rib. And after, we can see the manubrium, and we have a connection between the manubrium and the body of the sternum. Here is the connection between the manubrium and the body of the sternum. Is called the sternal angle. The sternal angle, it is also really important part of the thoracic cavity. Here you can see it. Why is it important in the orientation? Because you see that the second rib will form a joint here with the sternum. This is called the angle of Lewis, or angulus Ludovic in the Latin term. And after, you can see the body, and with the body will form a joint, the third and seventh rib, and finally we can see the xiphoid process. Let's see the next bones. The next bones, these are the ribs. Here you can see one of the rib. What are the main parts of the rib? Here you can see, we can divide the ribs first. I would like to talk about those. What are the main groups of the ribs? We can talk about true ribs. We have 1 to 7 here, 7 pairs of true ribs which will form a direct connection with the sternum. After, we can talk about false ribs, which will form a cartilage and after will join to the sternum. And finally, the two floating ribs, they have no direct connection with the sternum. So let's see now one rib and the main parts of it. First of all, we have to talk about the head. Here you can see on the presentation the head with green round circle. These parts will form a connection with the thoracic vertebrae. After, we can see the neck, and we have the body. We can talk about the costal angle. This is the angle here, this curvature. And I would like to also show you this tubercle, the costal tubercle, which will form a joint with the thoracic vertebrae. And which is really important, you can see a very special shape of the rib. So it's not a straight line like this. Always I'm using this in my practice to present the special shape of the rib with one flat page, because we have three different curvatures within the rib. The first one is like this. It's a simple curvature. One, we can see that the anterior and posterior part of it is forming like a C shape. We have another band, which means that the anterior part is locating a little lower than the posterior part. And finally, we have also a rotation like this within the shape of the rib. It will be really important during the movement of the rib when we are breathing in or out, expiration and inspiration. Also, I would like to tell you very important anatomical part of the rib, which is located in the lower part of it. This will be the groove, the ribs. Here we can find the main structures. My students, they know it, I hope, very well. These are the intercostal nerves and arteries and veins. And why is it important to know it? Because we know that if we do a puncture in the thoracic cavity, always we have to do it above a rib, because here will be the main important structures, the intercostal structures, the arteries, the veins. And also here in this separated picture, you can see the shape of the first rib, and we see here the tubercle for the insertion of the anterior scalenate muscle, and in front of and behind we can see the grooves for the main artery, the subclavian artery, and we can see also the subclavian vein. You can see these structures in this regional anatomy picture. And finally, I would like to show you the thoracic vertebrae. This is the one special vertebra. The main parts of it, we can talk about the body, what you see here in the middle. This is the vertebral foramen, where we can find the spinal cord. And you can see the lamina and the different processes. They have different processes. We can talk about the spinous process, which is very special. They overlap each other. We can talk about the transverse process, which will form a joint with the ribs. And finally, here we can see two articulating surfaces in the upper part and lower part. They will form a joint with another thoracic vertebrae, what you can see here in the picture. And I would like to show you very important articulating surfaces which will form a joint with the ribs. The first one is there. Here you can see we have two different articulating surfaces in most of the thoracic vertebrae. We have some special cases, in a case of the number 1, 11th and 12th, but most of them, they have two ones, a superior and inferior costal facet. Here you can see in the picture. And also we have an articular surface on the transverse process, what you can see here. And after, if we finish the description of the bones, we see the cage together, and the sternum, the ribs, and the vertebrae, you can see they form together the thoracic cage, which has a superior aperture for the structures, the trachea, the esophagus, the vessels. And you can see also the inferior thoracic aperture consists of the costal arches, the infrasternal angle, and the lower ribs. But it is really important to know that it is not the lower part of the real thoracic cavity, because here you can see that the border between the thoracic cavity and the abdominal cavity, this will be the diaphragm. And now, of course, we have to go a little further on, because we have a lot of joints, a lot of connections, and a lot of important muscles, what we have to mention. If we see the sternum, first we can describe some joints. For example, first we have a joint between the manubrium and the body of the sternum. But if you see this bone, it is visible that in the older ages it will ossify. And also we have connections which are called synchondroses between the sternum and the first rib, also between the ribs and so the bony parts and the cartilaginous parts of the ribs. Here you can see these connections. And we have to mention a syndesmosis, which means a connective tissue connection between the bones. These are the special external intercostal membranes, which is exactly the continuation of the external intercostal muscles. Here you can see the external intercostal muscle and the internal intercostal muscle. And of course, all of these structures, they are covered by the very special muscles, thoracohumeral muscles. I'm showing you here the Pectoralis Major. I would like to mention it because you will hear a development of malformation which will affect this muscle later. And now, finally, I would like to talk about the joints of the thoracic cavity, which are really important within the movement of the thoracic cavity during the expiration and inspiration. So the first joint, what I would like to show you, this is the costovertebral joint here, the joint between the thoracic vertebra and the rib. And it is very important. Here you can see that this joint has two parts. The first part will be between the head of the rib and the body of the thoracic vertebra, and the other part is between the transverse process and the tubercle. And now I would like to give you a little challenge. I would like to bring some bones for you, and I would like to ask the students to try to find which is the thoracic vertebrae and one rib, and I would be so happy if you could put together the correct position of them. I'm going, I think, to my students because I teach you in the practice. Okay, can you help me a little, Fatima and Nada? I'm bringing you the collection. So would you be nice to choose one thoracic vertebrae? This is a collection of different vertebrae. Very good. It's A. And here you can find the rib. Yeah. And I would like to kindly ask you to put together how it's working. It's not easy. Okay. First you have to find the articulating surface of the head of the rib. The head. Where is the head and where is the articulating surface? Yeah, this is the head. And we have to find the articulating surface on the body. Okay, I go here. It's showing you a little. Yeah, a little help. So this is the vertebrae. Thank you. So first of all, unfortunately, it's not the correct position, right? Because we have to turn it like this. This is the normal position of one rib. After we have to find the head of it, we have to put it to the articulating surface, and here you can see how the tubercle will form a connection with the transverse process. And my question is that how does it move? I give you back, and I hope that you can show me the movement of it.
So when you bring it,
Uh-huh.
it will expand. So it will move up.
Yeah, they move up and down, because what is the axis of this movement?
So
We have different axes, but it is running through the neck, right? Do you remember? I showed you in the lecture that the axis of the movement will be around the neck, so it's like a rotatory movement we have during inspiration and expiration. So I'm going back to my presenter position. I hope you are okay. And now I would like to show you that what we discussed with the help of the students. Thank you so much. So here you can see the head of the rib and the transverse process, and here is a connection, and the joint will move around this axis, which is running through the neck. Here you can see, and it is like a pivot joint, so we have rotation, and this is the movement, what the ribs they do. So here you can see a whole structure which will show you the movement of the ribs during expiration. So because of the special mobility of this joint, because of the elasticity of the costal cartilages, and because of the thoracic column, the flexibility of it, that's why during the movement, the diameter of the thorax will increase in the transverse and also the ventrodorsal axis. And here you can see a picture about one deformity, what Dr. Szántó will show you, one patient with a very, very severe scoliosis. And you see that in this case, the position of the ribs, they are really abnormal. And of course, it will affect also the breathing movement. And finally, only just some words about the embryology. I know that you don't like it so much, but you know, always I'm telling you that behind the anatomical structures, there are always, we have embryological origin. And here you can see what's the development of the muscles and the ribs. I hope you know this picture, the embryology picture, about the main parts of the mesoderm. So the muscles will originate from the paraaxial mesoderm, and the anterior wall will be, anterior wall of the thorax will be formed by the lateral plate mesoderm and one part of the ectoderm. Altogether we are talking about the somatopleura. So these are the main layers, and here you can see the muscles, the origin of the muscles. We can talk about epimer and hypomer. These are older definitions. Now we can use epaxial and hypaxial muscle groups, and from the hypaxial muscles will originate the three layers of the thoracic wall, the external, internal intercostal muscles, and the intermost within them, the three layers. And finally, only just some words about the sternum. Here you can see that during the development, we can talk about the mesenchymal stage, when we have two sternal buds. We have presternum and suprasternum. From this will originate the monoprium. And after, in the cartilaginous part, you can see sternal bars. They will fuse finally, and here you can see the final shape of the sternum. Of course, we could have developmental malformations during the development of the sternum. This is called sternal cleft. And also very severe when the anterior body wall is not closed. This is the ectopia cordis, but these are the pediatricians, they are working on it. And now I'm turning to the surgery presentation, and I'm showing you those malformations, what Dr. Szántó will show you. So here you can see the different malformations of the thorax. First, you can see the depression, when we have depression within the cavity. This is called the pes excavatum. Here you can see the carinatum, and finally we have a combined malformations. And now I would like to ask Professor Szántó to continue the lecture and to show the special clinical cases.
Hello everybody, good afternoon. Thank you, Andrea, for telling everybody so much about the anatomy of the chest wall. As I'm a thoracic surgeon, I would turn your attention towards the practical points, what we have to deal with. And the thoracic surgeons are usually doing operations in deformations which are affecting the anterior chest wall. This is the place for thoracic surgeon. Of course, there are posterior chest wall deformities as well, but they are, this is a field for the orthopedic surgeon or the neurosurgeons. And then we have mixed cases when we both have to be in the operating theater. As I said, the anterior ones, I will underline the Pectus Deformities. When you have some development problem with the sternum, it is depressed or it's in the anterior plane of the chest wall or in front of the anterior chest wall. Then the posterior ones, which is typically the scoliosis cases, and then combined ones, which Andrea already mentioned to you. What are the most common chest wall deformities in the anterior chest? The first one is the Pectus excavatum deformity, one in every 300 births. This is the most common. It's quite typical for young male patients, or at least the parents, they're bringing the children to us. So these patients are usually male patients, young male patients. Probably we have the same amount in women as well, but then they are probably more shy, or with the time they have some breast, which makes it not as big cosmetical issue as by men. I will go through them and show you some pictures how they look like and what we can do in such cases. So when we focus on the Pectus deformities, there are the two types. The first one, as I mentioned, the Pectus excavatum, is the one when the distal part of the sternum is depressed into the chest cavity. It's only affecting the distal part of the sternum. If it is a distal lesion of the sternum, then you have a clavicular problem as well, which is life-threatening mostly, and pediatric surgeons have to deal with such conditions. We adult thoracic surgeons, we don't see them. The other one is the Pectus carinatum deformity, when we pull out the sternum a little bit in front of the plane of the chest. On these pictures, you see how it develops. Which is one young man followed from 6 months to 15 years of age, and you might see that even by 10 months, 17 months, and so on, you see that there is something on the chest, which is absolutely remarkable at around the 10th age or 10th years, and with the time it looks like it is getting worse. Usually that's when the parents, they bring the children to us that, hey doc, there is something wrong with the chest of my child and it's getting worse. It's not getting worse, but then the size of the chest is becoming bigger and then it's more dominant with the time. What are the symptoms of the Pectus deformity? With this, you might see decreased exercise tolerance, which is interesting for me because have you ever saw a teenager who is having not any decreased exercise tolerance? Probably every time they are a little tired. It can be dyspnea at exertion and sternal pain, which is more interesting for us. And it looks like they feel when the heart is beating, because the heart is knocking on the sternum, and that's what they feel, that something is wrong. And if they exercise, then they have a higher frequency of this palpitation feeling, and that's why they come to us. When do we think on any operation? Of course, the surgeons as well and all the medical population likes numbers. That's the thoracic surgeons, they like numbers as well. So they try to find which is the most important number, what we can find out to describe this deformity of the chest. This is called the Holler Index. The Holler Index is the ratio between the sagittal and the frontal diameter of the chest. And if it's high enough, then a surgery might be indicated. I'm not on this side actually. I will tell you a little bit in details in the next pictures. But first, let's see how the CT scans of the thoracic picture looks like. What kind of type of Pectus excavatum deformity can we have? Either we can have a symmetrical one when both sides of the chest wall is depressed, but most of the time we have an asymmetrical type. It can be the sternum is rotated either to the left or to the right. Usually it's to the right. But on the next side of the picture you see some MRI pictures of the same chest, and you can see how much it squeezes the heart. But thanks God, the mediastinum is soft enough and the heart can be twisted and turned into usually the left side of the thoracic cavity. So if you hear from somebody that they are afraid that this deformity will compress the heart and the child will die, it's not true. So the heart is much more clever than this. So the indication for a treatment, we have, apart from the numbers, we like the classification, that's the second one. Thoracic surgeons do again. And if we say that the normal chest has a ratio of around 2 of the Holler Index, then we can talk about severe excavatum deformity about 3.5. I'm usually not very much interested in this. We do calculate the Holler Index, but I don't consider it as a very important indicator, why it's usually the cosmetic part which is disturbing. So the child is coming to your outpatient department and they will say that, hey doc, I don't like my chest, it's ugly. I cannot go to the beach, I cannot have my shirts off because it's ugly. And please, can you do something? And of course, if there are nothing, then you say, I don't do any surgery. But if this is a real Pectus deformity, then you think about the operation. What was the history of the operations, what we did? It's actually an invasive surgery with quite a big incision in the anterior chest wall, which is called the Ravage Surgery. Ravage was the one who described first this type of operation, when we had to resect on both sides of the sternum all the cartilage of the rib. All the cartilaginous parts of the rib, we have cut it away, and then we placed a metal bar below the sternum, but on the anterior surface of the rib. Just imagine. And then we had to sew it together. And if I emphasize that it's usually a cosmetic problem, we diminish a cosmetic problem with another one with a big incision in front of the chest. I don't know, I have made some of this operation, but it's not the typical what we are doing. Here are some pictures about a small child who had this surgery and all the resected cartilage from the chest wall. Well, how do we do the operation today? Thank God there is an even today existing and working surgeon, Donald Nass. He's a Canadian pediatric surgeon. He was the one who said this cosmetic thing is not very ideal after the Ravage operation. So why don't we do it from the side where it is not so prominent and the wound healing is much better? So why don't we do it with the use of an endoscope? And why don't we do just minimal incision on the sides of the thoracic cavity and put a longer wire in the thoracic cage? And that's what he did. Actually, they are, so in front of such a surgery, they have to bend a metal bar, which is individually planned to the patient. And then on both sides of the thoracic cage, we do some 2 small incisions, and with the help of an endoscope, we are following the route of this metal bar, which is then pushed into the thoracic cavity below the sternum. The 2 ends are out of the thoracic cavity. And just imagine this U-shaped metal bar is then placed right in the thoracic cavity, and then we turn it 180 degrees. And then it pushes the sternum forward. It looks like a painful operation. It's not easy to follow the first time, but the chest wall of this youngster, this teenager, is very flexible because of the cartilage. It's not so painful afterwards. How do we do it? There are some pre-operative pictures with a Pectus excavatum deformities, quite obvious that we have something here. And this is the post-operative picture. It takes us 40 minutes to complete the surgery, and immediately after the surgery, the patient looks like this. So the correction is 100% done. And these are some post-operative pictures from a patient. Everything is absolutely corrected. The patient is at home 2-3 days after surgery. Here I would like to show you a video, if I can. Okay. I don't think it will start. Okay, if I cannot, then I will go forward. I will check it again. It's embedded, so it has to be some technical issue. Oh yeah, okay, it's going. It's okay. So that's the chest wall, what we have with the Pectus deformity, and we have the metal bar bent in forward, and that's the plane what we have to find and push through the thoracic cavity, and in a fast operation we close it. And 2 years later we take this out, and that's the metal bar we are using. Okay, it's perfect, it's working. It's a very nice operation, and actually it revolutionized all the Pectus surgeries all around the world. So there is nothing, so there's really a rarity when we have to do the Ravage operation. We are doing it only by patients whose bone formation is complete. So above the age of 22, 25, we rather do that kind of operation. Well, we don't like it anymore. So we are using the NAS operation, but we wanted to make it even more individual, even more individually planned. So please let me introduce what we have done to make this kind of operation even a little better, maybe the use of a 3D technology. Our university is having a 3D center, and that's what we used for making a little tuned up operation. So in front of the operation, by the time we are planning the intervention, we are asking so we are doing a chest CT instead of a chest X-ray. We are using a so-called ultra-low dose CT, which means the radiation, what we are using is very minimal. But even with this technique, we can have a 3D picture of the thoracic cavity, individually of the same patient. This is turnable and we can check everything on it. With this reddish square, I don't know if you see it, there is something which we don't see, that's the cartilage. So we can tell which part of the thoracic cavity is bony and which are the cartilage part of it. Even just to enjoy you, that's the lung inside of the thoracic cavity on this 3D picture. We are really interested how is the flexibility of the chest cage, and that's why we are using a very easy method to find this out. We ask the patient to inhale and to exhale. And there you see the difference between breathing in position, which is this purplish color, and this greenish is the breathing out position. And because of this, we can calculate the flexibility of the chest wall. After this, we can plan the exactly, precisely planned metabar, what we are going to use for the operation. And this is even a detailed view what to do. The bluish part is the cartilage. Now in this left side, the lower picture shows you with red. These are the parts of the thoracic cavity which are movable. So that's where we can intervene. And the right upper picture with this bluish color shows us which is the original chest. And even this depression of the sternum can be cured. And this golden color part is the one what we would love to achieve. And for doing so, that's the plane or that's the metabar to use. Even we have an aid where to put this metabar in front of the surgery. As you see, the 3D center prints out a help, this aid, to find exactly the best position for the metabar. And even if you place the patient in different positions on the operating table, you find the exactly designed place to insert the bar. These are the pictures, the post-operative low-dose CT pictures with the plates inside. We hope that with this 3D technique we can achieve the most, the best and individual solution for each patient, and that's what we are doing now in a bigger series. The opposite deformity compared to Pectus excavatum is the Pectus carinatum deformity. When the distal part of the sternum is in front of the chest plane. These are the CT pictures. You see it's like a heart-shaped chest, and this is more obvious even here that the distal part is in protrusion. To operate this is not so easy. We cannot do an inverse of the Pectus deformity with the insertion of the metabar, but we have to cut out a part of this straightened rib, and then we have to push down the sternum in the right position. Sometimes we even have to ask for a conservative help to put in a cage which depresses the sternum in the right position. This is a successful operation, but we cannot bypass the problem of this incision in front of the sternum with this deformity. On the conservative side, that's which is chosen in many pediatric surgeons as well. So they don't do surgery, but they do this help with this cage. It's like a rucksack on the back of the patient, but it's just with this plastic belt. They are depressing the distal part of the sternum. They have to wear it for 1 year or even more, 2 years continuously, or as long as they can tolerate the situation. It's not a type of typical surgical intervention, because surgery is, we like to cut and then we are happy. It's a long-term disturbance. It's not the type what we do. Then we go to the third group of deformities I would like to talk about. This is a Poland syndrome. It has nothing to do with Poland, the country, but with this guy who was called Poland. He is an English guy who lived in the 19th century, and he was the one who described this condition first. This is a condition when we have a congenital absence of the Pectoralis Major and the minor muscles. With this, we often have a lack of ribs. There is sometimes breast abnormality, some chest wall depression, and we can find missing fingers or even hands on one side of the chest cavity. It is not really common, but even in my career, in my 20 years of career, I have seen 3 patients we had to operate on. On this picture, in the middle, you see some problem of the chest cavity. There are some missing ribs, and there are some interpretations on these pictures of this condition. The left upper picture, you probably won't even recognize it first, because there's a slight difference between the pectoralis muscle on this gentleman, and even on the lower picture on this gentleman, you don't see it very obvious. On the other side, by women, it's more obvious, usually because it's after the teenager age, you see that there is size difference in the breast. And usually, how they come is that a clever plastic surgeon says, I don't want to operate you with an implant, but I will send you to a thoracic surgeon. And because we have to sometimes make some replacement of the ribs or muscles or whatever. In the middle, you see the CT picture. On the left side of the patient, you see the muscle. In the right side, I'm not changing the sides, but in the CT, on the left side, you see the right one. And there is absolutely missing pectoralis muscle. Okay. What can we do in such a condition? Of course, the easiest is to put in a silicone implant, which can be a solution. If the movements are okay, then if the arms are working well, then the easiest is to put in an implant. It is more difficult, but it's really the best solution, what you probably heard about the last lectures previously in this series of lectures, to put some muscle instead of the lacking one. Like a latissimus muscle flap can be used as a replacement for the pectoralis muscle. It looks like absolutely normal. And then a good plastic surgeon can make the two sides very balanced, and you don't discover this congenital abnormality. If you still have some missing ribs, there is a next generation opportunity, and we are using 3D technology to print out or to somehow fabricate the ribs and augmentation for the rib cage. This is a little future still, but that's what we can do, and we cannot wait to get to this situation. And lastly, I would like to show you a combined deformity, which Andrea has already mentioned in the first presentation. This young lady was 13 years old, and she was presented with extreme scoliosis. The extreme scoliosis consisted of the rotation of the vertebral column by 130 degrees. Just to make you obvious what is this problem, usually a severe scoliosis can be reduced or have an implant to make a stronger vertebral column situation if you have a scoliosis around 60-70 degrees. And she had double as much scoliosis. I don't want to frighten you, but this is the picture what we saw. This is an X-ray. You cannot follow where the vertebral column is. On the right one, which is a three-dimensional CT scan, you see it, but it's like a snake, and it's absolutely abnormal. I thought first that we are dealing with a much easier situation, but it was not the case. And for reconstructing it, the orthopedic surgeon didn't have any tool. As I already mentioned, they can only deal with conditions where the rotation is less than 60-70 degrees. It was huge, and we had to get back to this situation and so turn it or straighten it a little to get back to this state when the orthopedic surgeon could do the Cleft operation, what they do in such a case. And we had to find out a mixed solution what to do, and thanks God there is an opportunity how to solve it. There is a factory, a company who is doing some expandable bar implants. We had to place one side of the implant on the pelvis, the pelvic bone. It's placed on the top of it, in the back of this patient, and another leg, so at the other end of this implant, was placed on the second rib, very close to the vertebral column. And we started to push it upwards, even on the first surgery. And in the middle, there are screws, two little screws, and to straighten and to elevate the length of this metal bar, the orthopedic surgeon, he only has to do some small incision above the screw and then turn it a little. Every time in every operation, you can length or increase the length of the metal bar by 2 centimeters. And we inserted it. That's what you can see on the next pictures. That was the spina iliaca, and there is somewhere the vertebral column, and this is the lower end of the metal bar. Then you see it here, you might see it here, and then it goes upwards on the posterior wall of the chest cavity. And that's the uppermost part when we are then fixed to the second rib, and we started to elevate it. Here you see we had to even make a thoracotomy. We had to cut through the intercostal muscles because there was so much stretching, we couldn't continue, and then we had to put in a plastic implant instead of the intercostal muscle. And even after the first surgery, we were around 100 degrees, and with 3 small operation and lengthening of this metal rod, we achieved the light situation, and the patient could receive the orthopedic or the vertebral column surgery, the orthopedic type of surgery. And you might follow it. This reddish rod is the one which is the orthopedic wires, which are straightening the patient. By doing this operation, it remains there, but the patient is now without any pain. She's able to walk, she's able to sit, which was absolutely not imaginable in the surgery. So she was lying in the same position the whole day, and now she can walk and now she can sit. So it was a combined situation. She had some kind of Pectus deformity as well, but that was the least problem. So I was kicked out of the operating theater, and I couldn't correct the Pectus deformity. There was no need for this, because she was what she was capable of. The lungs are working quite well for this demand. Okay, I think that was the last picture of my lecture. So I would like to thank you all for your attention. And if you have any questions, I'm very happy. And together with Andrea, if we can answer it. Thank you very much.
So if you have any questions from the room or from the other university students, just please raise your hand and switch on your microphone and ask your questions. We don't see any written questions in the chat, but yes, I see it, Maastricht University, so please switch on your microphone and ask your question.
Hello, thank you very much for your amazing presentations. Thank you to both of you. I would like to know what is the minimum age of the patients who require the correction when there is the pectus excavatum? So what is the minimum age that you operate on usually?
Okay, thank you for your question. As I showed you, there is an obvious deformity even in younger ages. But the patient, they have to be fit for surgery. We have to achieve a situation when the chest is big enough for not growing too much after surgery, because we have to remain this metabar for 2 years in the chest cavity. It's not very ideal if the chest is growing in that time. So we like to do it with an age of 16 or 17, and we take out around 20 years of age. The pediatric surgeons, they do it even in younger ages, but we adult thoracic surgeons, we like to do it after, around the 60 years. 60 is the best.
Oh, thank you very much. Thank you for your answer. Thank you.
Further questions?
I would like to ask a question. I'm thinking about when you're doing the surgery, I mean, if you insert the metal bar across the under the ribs, I'm thinking that maybe there will be one kind of the side effect. For example, the lungs will be depressed. And what will you do in this situation?
Actually, how you can insert this metal bar is you have to know how to do it. But you have to know it, but what I do to be more secure in this situation is that I'm following the whole way how we insert the metal bar with the camera. So we insert the camera, and ideally you don't even go inside of the thoracic cavity, you don't cross the pleura, you remain outside the pleura, and you can have a tunnel outside of the pleura, the parietal pleura, and then you slip below the sternum. That's why you have to have some experience in this field, but to make it most secure, that's why we are following it from one side, first from the left side, and if we manage to go to the right, we are very close to the right hemithorax, then we switch the position, and then the tunnel is fabricated in that time, and then we follow the metal bar, and that's how we push it through. And as the U-shaped metal bar is then quite easy to be placed in position. Afterwards we turn it, and then you make a bigger room for your lungs as well, because then you have a bigger hole.
Thank you very much. It's very impressive.
Any more questions?
Just a very short question. Do you work on these cases with orthopedic surgeons, or is there any scenario when you're together with the scoliosis specialists? Or
yeah, we are working together with the orthopedic surgeons. So if they find something is above their knowledge or their experience, then they call us, and then of course we have time. So they are not acute operations. We have time, and then we sit down. We have some 3D reconstructions. We think it over. We plan it for a longer time, and then we decide for surgery, and then we are together in the operating theaters. They are mostly unique operations, and then you make some improvisation as well during surgery. But they are nice challenges in that way.
and do the patients feel this bar that it's inside, or they just get used to it?
No, they don't feel it. What they feel is that the outline of the thoracic cavity is changed. It's like they report they cannot describe it very easily. It's a dull pain. It's like somebody is pushing the ribs from the side. But then they get rid of it 2 or 3 days after surgery. Of course, we are having a very precisely planned painkiller protocol after surgery. But they have to stay up the next day after the surgery. They have to leave the room, the patient's room. They have to sit up, they have to exercise, they have physiotherapy, and in some days they are fit to go home, when it's usually not the bony part which is hurting, but the muscles. Because it's like after your exercise, the next day, if you stretch your muscles, it's painful. And that's what they feel. So the muscles are stretched. If the stretching is over in 2 or 3 days, then they can go home. And in 1 week after the surgery, everything is all right. And after 1 month of surgery, they can do whatever they want. So they can ride a bike, they can swim, they can do whatever they want. Even we had a first league basketball player among our patients, and they kick each other, and they don't feel anything. And they always come back that, hey, doc, can you leave it there? Because I don't need a second operation. Well, of course, we take it out. Taking it out is even easier because we only have to cut it from one side. And it's like to pull out a sword from a housing. That's how we put it out, and it's a 5-minute operation if we are lucky.
Next question. I still see a raised yellow hand at Maastricht University. Do you have another question?
Oh, apologies, that's just me forgetting to put it down. Thank you.
No problem, no problem. So any further questions from individual participants of the Zoom meeting? Maybe? I have a question, actually. So the patients are mostly young people, young men, right? Mostly. Do you have sometimes, rarely, adults or like 50-year-olds who just could cope with the aesthetic problem for a long period of time, and suddenly something can change in their life and they realize they need this kind of surgery? Do you have this kind of experiences with?
Yes, we have. Sometimes the problem is that sometimes a pediatric doctor says to a patient with a Pectus deformity that you should swim. It's actually international. You should swim, and you will get it. You get rid of this problem. You won't. That's why I showed you these pictures with this child who is growing up. So you see it, but it's not obvious in a childhood. But I'm really happy. I don't say anything against this, because then when they come to us in the teenager age, then they have very nice muscles. It's okay. But sometimes somebody reaches the adulthood and they don't face that there is a possibility of reconstruction. And then we have to get back to our previous type of operation and do the ravage operation. The thing is that the bony bone cannot be bent, so you only can cut it in two, or you cut a part of it. And if you cut the part of it parallelly to the sternum, then you can insert a plate below or two, and the patient is okay. The thing is that even the ribs are quite deformed in most of the cases in an adulthood, so the cosmetical part is not as successful. But sometimes we do it because with an older age, when we start to bend a little, then the lung function of the patient can be restricted. So, of course, I'm not a plastic surgeon, I'm a thoracic surgeon. As I said, I'm doing it for the cosmetic result, which is not really true, because I do it for giving the patient a better lung function test for ages. Because if I don't correct it, then the lung function will be restricted later on. So if we correct it, then we make a better circumstance for the patient to have better lung function. So the answer is yes, we face them. We don't like as much this type of operation, but sometimes we have to do.
Thank you. No more questions. No more questions from the online participants. Yeah, there is a question at Maastricht University, so please ask your question.
Thank you. We have a question here.
Yes, thank you for the lecture, first of all. So I hope my question is not stupid, but as far as I remember, between the thoracic wall and the pleura, there is a fluid, and it's always in contact. So because that's how like expression and inspiration works. And can it sometimes happen that due to the extra created dimensions, the extra created space, the pleura cannot adhere to the thoracic wall? So the breathing mechanism is not working properly?
Good question, but thanks God had arranged us a nice situation and a very flexible lung. So so the sheet is, what we are using is in between, so the outside of the parietal pleura and the chest muscles. So that's what we are using. So we don't go inside the chest cavity, ideally. Well, if we go in, it won't bother this fluid in the chest cavity, because the lung expands so easily to the bigger hole what we have created. And on the next day, we are always doing an X-ray the following day after surgery. We barely see any pneumothorax, so a restricted lung. So it's usually absolutely filling the whole chest cavity, and this fluid disappears very easily. So it's actually not a problem.
Okay, thank you.
Thank you.
Thank you for the great question. Okay. Any more questions? Okay. So it seems we had a very interesting session today as well. Thank you for the lecturers that they have done this clinical anatomy session of today. So we may give an applause again, maybe for. And as host in the series, I would like to say thank you for all of the colleagues from the other universities who took part in this series, especially for Maastricht University, who have came up with the idea to do this series, and I hope we can do that in the future again. I think it was a successful one, even if we just started a little bit late. We haven't had time to officially announce this course and plan properly, but still it was kind of a trial series, and we haven't had major problems. So thank you very much for the opportunity. Thank you.
Thank you, Andrea. Thank you.